So thank you to everyone who has joined our webinar. Today it is the third in the series, and as you can see from the slide, today we're going to be talking about optimizing MIYCN policies and programs through strengthening data and information systems. We've put an excellent panel together for you, and we have three objectives for the meeting today. The first one is to raise the awareness of the new guidance and indicators that are available. The second is to explain the role of qualitative data for program design and implementation. And the third is to be able to share technical updates and country examples of how best to use data to inform policy and programs. All really important as we work in the field of public health with our passion of improving maternal, infant, and young child nutrition. So with no further wait, I would like to hand over to Roland Kupka. He's the Regional Nutrition Advisor for UNICEF East Asia and the Pacific. And Roland, I don't think we can say you are new anymore, but it's lovely to have you with us, Roland, and over to you to do the opening remarks.
Thank you, Jane, and hello, everybody. And indeed, I feel at home already in this great region. So welcome, everybody, to this third and final webinar of this annual regional series on creating MIYCN-friendly health systems in South Asia and beyond, Southeast Asia and beyond. As UNICEF, Alive and Thrive, and Irish Aid, that is as the organizers, we're really glad that so many of you were able to join us. I see we have more than 60 participants at this point, which is really great. As Jane has mentioned, we will be discussing how to strengthen data and information systems in this webinar. And as the organizers, we do hope that from the webinar, we will be able to take away some good leads on how to strengthen these systems, especially as we also work towards the workshop that we are planning for the first quarter of 2021, and where we will have a chance to then integrate all the information that we've been discussing in the webinars into our national action plans. As Jane has mentioned, we will get to learn today about the latest guidance on standardized indicators for young child feeding practices, but also how to collect data on SBCC and diet quality and changes in diet quality. We will get to hear about some regional efforts, and then best of all, also some country experiences on how to measure such data through surveys as well as routine methods. I think this topic is so timely because in the context of COVID especially, it's become so apparent how important it is to be able to collect robust data on diets and on services in a timely fashion. I think for us as a nutrition community, it's so important to be able to document the effects of COVID on diets and services, and for us to realize that we can't always rely on our standardized population-based services to do so. I'm also really glad that in our discussions today, we will be able to not only look at the consumption of healthy foods, the traditional ways of measuring infant and young child feeding practices, but also to discuss how to measure the consumption of unhealthy foods such as sugar-sweetened beverages and other tracer junk foods. Those are, of course, really important agendas that we need to be able to address in the region. On the UNICEF side, the better tracking of indicators of diet quality across the life course is a definite priority for the next year. And it is indeed something that we want to deliberate on further over the next weeks. So therefore, this webinar is hugely timely for us, and I hope the same will hold true for all of you. Big thanks to Jane as our facilitator, the presenter, the organizing team, and certainly all of you as participants. I do look forward to the presentations and the related exchanges. Thank you.
Thank you, Roland, and we really appreciate the work that you and your team and our Alive and Thrive team and our Irish Aid funders put into making these webinars happen over this difficult time. So we've got the two perfect people to do our opening framing presentation for you today. And I'm going to hand over to both two J's, Jessica Blankenship, who I think you all know as the Regional Nutrition Specialist for the UNICEF East Asia and Pacific Office, as well as Jennifer Cashin, who I think you also all know as the Regional Technical Specialist from Alive and Thrive. So Jess and Jen are going to take us through the framing, and starting with you. Jessica, over to you.
Thank you, Jane. So I would like to start with just coming back to this cyclical nature of data collection using to inform programmatic design and modification, and that I think we often, actually let me go on video. I think that we often focus on these major outcome indicators, so stunting, wasting, overweight, exclusive breastfeeding. And it's important to note that it is just as important, or even more important in some aspects, to also be able to monitor the routine systems and the indicators, the process indicators, output indicators that go to determine how effective our actions are to achieving these ultimate goals. Throughout my short presentation, I'll be referring back to how these new indicators, these new tools that I'll present, can be used to not only measure our progress against goals and targets, but how we can actually measure the effectiveness of our programs and how we might need to do course correction or program modification to make them more effective. So the first, I wanted to raise awareness that in 2018, the global standardized IYCF indicators were modified and updated. There's now a total set of 16 indicators. I won't go into elaborate details here, but there were several indicators that were updated or modified, and then there was a group of new indicators which were suggested. You see here 4 of the modified indicators. These are all collected now through all mixed surveys and DHS surveys. And the updated methodology, the syntax, should all be used for national nutrition surveys and other surveys where we want to be looking at these output and outcome indicator levels. We also have a series of new indicators, and this is quite exciting. Roland had referenced this in his opening as well. So for the first time, we have global standard indicators to capture unhealthy eating. And this is when we're looking at the IYCF collection for children 6 to 23 months of age. There are 3 indicators which are being suggested and collected routinely. 1, consumption of sugar-sweetened beverages. 2, tracer junk foods, which are highly processed, fried, savory snacks, processed sugary foods, cakes, cookies. And the 3rd one is actually measuring the lack of nutritious foods in the diet. So it's children who consume 0 fruits and vegetables. Once again, these indicators will be included in all DHS and mixed surveys, and then they should be included in all future national nutrition surveys moving forward. We do not, unfortunately, have global standardized indicators to measure more of the process level. And one of the most important indicators of looking at our actions at the health center level is the measurement of the receipt of IYCF counseling for the past 6 months or definite time period which you're interested in for your program. The collection of this indicator is strongly encouraged because this lets us actually measure what is the coverage, what is the scope of our program to provide IYCF counseling. Additionally, it can be extended with the time that you have available and the resources that you have available to look at what specific messages are being received, what is the quality of the counseling that's being provided. So this indicator is really vitally important to understand what is the quality of the counseling, who's receiving counseling, and how should we modify our IYCF counseling program to better meet the needs of the population. As well, to sort of transition from the outcome indicators and then the receipt of counseling, but we need to base our counseling messages on information that we have on dietary quality feeding practices, on food consumption, food purchases, and the dynamic of the food environment. In order to do that, we need to better understand these factors. And I think there's been a lot of movement recently in the last few years on development of indicators and standard data collection methodologies by which we can better understand what is the dietary quality of young children and their mothers, what are the impacting variables which influence what children eat. The first is minimum dietary diversity for women. This is now going to be routinely collected through all DHS surveys, and I highly encourage the collection through other national surveys. It is very similar to the IYCF indicators with the 24-hour dietary recall, and it's looking at the consumption of major food groups, including healthy food groups, but also the inclusion of sugar-sweetened beverages, junk foods, sweetened foods, and it can be measured very similar to the IYCF with no fruit and vegetables and consumption of unhealthy foods. Second is the diet quality questionnaire. So this is a 29-question quick survey, which can be enumerated in 5 minutes. And it is going to be part in 2021 of the Gallup poll, which is quite exciting in 90 countries. This will be collected for adult diets. But what's exciting about the diet quality questionnaire is for the first time, we'll have diet quality information for adults for 90 countries at the global level. And it's not just looking at consumption of healthy foods, but also unhealthy foods, highly processed foods, and being able to look and rate the quality of the overall diet of men and women. To support also the environment over market access and food consumption, it's important to also collect indicators such as change in household market access, household food security or insecurity, and cost of the diet. These provide more information on what are the influencing variables to the diets and access and availability of affordable and nutritious foods. I just wanted to quickly run through when we're talking about data collection and looking at what is influencing what children eat and what mothers eat. It's important to note that our environment is dramatically changing and dynamically changing. So food is not consumed only at home anymore. So UNICEF worked with partners to develop just a short series of questions measuring the consumption and purchasing of food outside of the household. So for example, this first one, including in a survey asking how often are prepared or commercially produced meals consumed outside of the household. And as you can see in a Jakarta urban sample of children 12 to 23 months, nearly 50% of children had consumed food outside of the household every day for the past 7 days. Similarly, we ask a little bit more and we dig into what are the most common outlets and types of foods which are being purchased. And then lastly as well, what is the rationale behind why the foods are being purchased from outside of the household? All of these questions would help us then prepare and modify our existing program. So if we're providing IYCF messaging, we have to know what are the influencing factors which then determine and influence children's diets, consumption patterns. If there's no time to cook food at home, having our messaging focusing only on home-cooked food isn't going to necessarily resonate with our population. So it's important to understand what are those drivers influencing the practices that we see, and then linking them back to our programs so that we can strengthen them and make them better targeted. We also are seeing that it's important to measure all of these indicators in normal situations, but we need to be routinely implementing them and measuring them. And COVID-19 has stressed this point, that we need to be able to measure what are changes in food security and consumption patterns due to the impact of COVID-19 and economic implications. UNICEF HQ has designed a series of questions which can be tacked on to the existing IYCF and Women's Minimum Dietary Diversity questionnaires. And it looks at measuring what has been the change in different food groups due to COVID-19. These additional questions were added to a series of urban surveys implemented in Indonesia and Philippines. This is very preliminary data, but what we see here is that there's been dramatic reductions across the board in consumption across all food groups. So for example, you see reduction in the consumption of nutrient-rich meat, poultry, fish, and organ meats, but you also see the reduction in sugary food consumption. So it's important to note how our economic restrictions impacting the diet and what's being consumed? And then how can we modify our programs, our counseling messages to better meet those demands? It's important to note here that when asked what is the main reason for the reduced consumption, the number one response was that the purchasing power of these foods was reduced due to COVID-19 and economic loss. In summary, we have a set of global standard indicators. We have questionnaires and syntax. These are free for use and should be widely applied to measure our global outcome indicators and output indicators for comparison across countries. We also need to take into consideration, we can't just measure what the output and outcomes are. We need to know how to modify our programs to best achieve our goals and results that we're looking for. To do that, we need to understand the food landscape, and these landscapes are dynamically changing. We need good quality data. We need to have data on quality, quantity, and the dynamics of food purchasing. And we need to also be able to do that in a timely manner, routinely collecting to look at the changes as we have a very dynamic and quickly changing landscape in front of us. The good news is that we do have a lot of available indicators and data collection modalities that we can pull from to better understand. We can use these available indicators to design our programs and policies to prevent increasing food insecurity and deterioration of diets for young children and their mothers. Okay, so I would now like to hand over for the presentation to my colleague, Jennifer Cashin. Thank you very much.
Hi, everyone. Good morning, good afternoon, good evening to all of those joining us. And thank you so much to Jess for the excellent presentation and update on the new indicators for measuring maternal, infant, and young child nutrition. My name is Jennifer Cashin, and I'm a regional technical specialist for Alive and Thrive Southeast Asia, based in Yangon, Myanmar. And it's my honor to be here with you today to talk about the use of data for behavior and policy change. Next slide, please. So, data. As Jess mentioned in her presentation, to have impact, it is essential to collect and use data throughout the entire program cycle to understand the situation, design the approach, activities, and communication materials, to shape advocacy messages and improve program implementation and management. And though the needs might differ by audience, when used strategically, data can reach anyone, from employers and business owners to grandmothers and religious leaders. In the next few minutes, I'll talk about the use of data for two purposes: designing and implementing behavior change programs and advocating for policies that are more supportive of good nutrition. Starting first with behavior change. If we hope to change nutrition behaviors, we have to start with data. Next. Why do people do what they do? Nutrition behaviors are shaped by individual and societal level determinants, and they influence each other, so we need to understand both. Social determinants can include the norms of groups and communities, culture and beliefs, and perceived risks of adopting or not adopting the new behavior. Behavioral or individual determinants can include knowledge, skills and abilities, opportunity and access, as well as more intangible factors like desire, motivation, convenience, and comfort. Next. In order to find out why people do what they do, we need formative research. We need to learn from the people we are interested in helping, supporting, or working with. And we can't just ask people what they know or even what they do because it doesn't always answer the question of why. There's increasing recognition of the need for new and innovative methods for formative research to uncover the depth of human experience and to meaningfully engage communities in the process. This slide shows some formative research methods categorized by level of community engagement. I'm sure you're all familiar with research methods like interviews, focus groups, and food diaries. More participatory techniques include observation, projective techniques, trials of new behaviors, and attribute ranking. And at the most participatory level are people-centered methods such as immersion, video ethnography, and co-creation. Next. In partnership with the Tenoto Foundation, Alive and Thrive recently worked with Empatica to conduct a formative assessment of complementary feeding and early childhood development, as well as maternal nutrition practices in Indonesia to fill knowledge gaps in this area. Based on the principles of human-centered design, Empatica's people-centered approach involves experiential immersion, ideation, and prototyping of social and behavior change communication solutions. In February 2019, during the immersion phase, researchers spent 4 days living in the villages with families. During this time, researchers had conversations with them, observed them with their children and met their neighbors, attended health posts, growth monitoring sessions, and observed and discussed interactions with service providers. They also participated in household work, agriculture, and community activities. In June 2019, the teams went back to those communities and facilitated the creation and testing of locally generated solutions to the challenges that were identified. Families and communities then trialed these solutions and reported on their progress to the researchers. And these collective findings were then synthesized and shared with national stakeholders to inform Indonesia's large-scale stunting reduction efforts. Next. But once we have the data on what people are doing and why they do it, how do we choose which behaviors to focus on? By using the tool on this slide, we can work to prioritize key behaviors based on their feasibility on the x-axis and on their potential impact on the y-axis. Feasibility refers to how easy a behavior is to do. Impact refers to both the efficacy of the behavior on health, which comes from global data, and also on whether there's room to improve, which comes from local data. So if the prevalence of a recommended behavior is low, we can say that there's a lot of room for improvement. Next. Here's an example from Cambodia. In a recent workshop hosted by the National Nutrition Program, World Bank, and IDE, stakeholders were asked to prioritize separate complementary feeding behaviors based on their feasibility. In other words, are they easy for caregivers to do, and their potential impact, or is the current uptake low and is there room to improve? In the top right quadrant, you have behaviors which are both easy for caregivers to do and relatively uncommon. Those behaviors included providing eggs and fish to young children, both foods which are accessible and affordable to most, and introducing animal foods at 6 months. Most members of the family do eat animal source foods regularly, but these foods are not always provided to younger infants. Behaviors that were classified as low impact and difficult to change include clean, safe drinking water. Not because clean drinking water is not important, but because most families have access to it, and water access is difficult or maybe even impossible to change for a purely social and behavior change program without an infrastructure component. Behaviors that were classified as high impact but difficult to change included feeding meat every day, since this is not feasible for most households. In the low impact but easy to do category, you have behaviors which are impactful but already common, like feeding fruits and vegetables and vitamin A supplementation. Next. But it's all too common for programs to conduct formative research and gather a lot of evidence and then fail to translate that evidence into actionable opportunities for change. Often the strategies do not reflect the detail that was uncovered, and the same predetermined activities are implemented despite what was found in the formative phase. Using a simple analysis framework like this one can help to ensure that there's a link between the findings from formative research and the final strategy and approach. I've taken the sample behavior of feeding eggs to young children as an example here. Next. Now let's move from caregiver behavior to the behavior of policymakers. How do we use data for advocacy? Developing the evidence base is an important part of effective advocacy. Evidence is needed in order to establish the urgency of the issue, provide proof that the intervention or the policy will be effective, and reflect the needs of decision makers. The data that policymakers need and want is sometimes different from what public health practitioners are used to collecting and reporting on. We often have to get creative and forge strategic partnerships to access and effectively use data for policy advocacy. Next. And the type of evidence you need depends on the decision to be made and the type of decision maker. Here are some examples. Scientific evidence helps us to establish the health problem and identify the solution. Global evidence is often useful here. Economic data and information can be a key driver for decision-making of policymakers, and it can refer both to the cost of undertaking a policy change and the potential return on investment. Sociocultural evidence establishes the current landscape for a given behavior and makes the case that a policy shift can help address a health behavior in a specific context. For example, the surveys that Jess described in her presentation include indicators on nutrition behaviors at the country and subnational level. We can use this data to understand the scope of an issue and identify behaviors that require the most attention. And finally, original empirical research can help build the case for very specific claims or points. In Vietnam, they recently used data from an existing workplace lactation support program to estimate the cost of making these programs mandatory for large businesses. A policy paper on this topic helped to influence an upcoming revision of Decree 85 on the rights of female workers. Next. In addition to evidence, partnership is essential for effective advocacy, and this regional coalition is proof of that. In February 2019, Maternal and Child Nutrition published this supplement on an evaluation of the advocacy efforts of this very group, convened by Alive and Thrive and UNICEF, to support governments in fostering enabling environments for better IYCF in Southeast Asia. Taking advocacy around the code as an example, the authors identified two key drivers of policy change, namely using an explicit advocacy approach and also the mobilization of a strategic group of actors. A set of 15 unique critical tasks were identified as triggers. Each task was necessary, but not sufficient alone for triggering policy change. And many of these tasks, not surprisingly, included data, such as legal assessments, development and utilization of checklists, media scans, and then once legislation was passed, compliance assessments. Next slide. So in conclusion, coming full circle back to the wheel of data, effective MIYCN programs use data at every step of program design, implementation, monitoring, and evaluation. We need quality, in-depth formative assessments to understand the why of what people do, so that we can design interventions that address the reality of people and communities. But it's not just the data you collect that's important, but how you use it. Even existing data can be used in innovative ways to prioritize key behaviors, identify small doable actions, and can also be packaged differently to meet the needs of policymakers. And with this, I'd like to turn it back over to Jane, and thank you all for your time.
So thank you to both Jessica and Jennifer. I think you will agree that they really have showed us that although we keep hearing it, and although we know it, we aren't always doing the measuring, and if we aren't always doing it to the quality standards. And yet I wrote down while they were speaking, there's 4 P's for why it's so important. The first is without quality, quantitative and qualitative data, we can't have good programming, we can't have good policy, we aren't able to prioritize, we aren't able to push our messages, and that means we won't get positive progress. So it really is important and cannot be neglected. A reminder to any of you, if you have any questions for either Jessica or Jennifer, please go into the Q&A box on your screen and type in your questions there. We do have a panel discussion coming up. Now let me hand over to hearing a little bit of a story from a country, because we always know how much we enjoy country sharing. So it is a pleasure to welcome again Anne Provo, who I think everybody knows because she has been in the region for a while, and the nutrition specialist from the World Bank, who's going to, as you can see from the title, be sharing with us a story from Cambodia. And your storytelling time starts now.
Thanks, Jane, and thanks so much to UNICEF, Alive and Thrive, and Irish Aid for this opportunity to share a little bit with you about what we're doing in Cambodia. I'm Anne Provo, a nutrition specialist in the World Bank's East Asia Pacific region, and currently relocated from Cambodia to the US during COVID. Next. The program I'll be describing to you today is part of the Cambodia Nutrition Project. It's a 5-year, $53 million investment from the Royal Government of Cambodia, the World Bank, the Global Financing Facility, German KfW, Australian DFAT, and the Health Equity and Quality Improvement Project. The project's objective is to improve utilization and quality of priority maternal and child health and nutrition services. And it's implemented both through the Ministry of Health and through the National Committee for Subnational Democratic Development Secretariat and the local government or subnational administration in 7 of Cambodia's most in need provinces. Next. Next slide. please.
The next slide is up, Anne, so maybe you're not seeing it, but you can speak to it.
I will do that then, thanks. So why do we focus on quality? Cambodia has a unique opportunity to leverage the existing National Quality Enhancement Monitoring System to improve MIYCN service delivery and outcomes. The NQEM is a nationwide system. It was initiated in 2017 and reached full scale in 2019, and incorporates a quarterly quality assessment of every public health facility, health center, or referral hospital in the nation. Every facility receives a quarterly assessment from a certified assessor that includes different dimensions of quality of care. The structure, be it the management, financing, staff, and infrastructure of the facility, the process of care, both the knowledge and technical competency between the patients and providers, and the outcome quality, which is based on a client satisfaction survey. The NQEM program is fully owned by the Ministry of Health. It incorporates an independent verification entity, as well as a performance incentive for health facility staff to improve their quality scores. Next slide. So why focus on the MIYCN in the national system? As we were designing with the Ministry of Health, the Cambodian Nutrition Project, it was clear that despite the numerous high quality and evidence-based nutrition guidelines, there still was lagging progress on MIYCN behaviors and the key nutrition outcomes. Little was known about what was happening on the front lines, the quality of that counseling interaction, and the extent to which it was actually delivered. So by integrating these MIYCN indicators into the national system, provided the opportunity to focus on generating data on service delivery and increasing the visibility, financing, and sustainability of nutrition interventions. Next. So based on the Ministry of Health's guidelines, as well as national, international guidelines, a maternal and child health and nutrition scorecard monitoring tools were developed. These include structural indicators on the essential maternal and child health and nutrition equipment and supplies, availability of guidelines and materials, presence of BMS promotion within the health facility. It includes provider knowledge and skill tests. So you can see there are a number of competency tests and vignettes which are randomly selected and applied for to health facility providers. And then client interviews that follow up on patient satisfaction with the interaction with the healthcare provider, as well as the receipt of specific elements of the ANC or GMP contact, including counseling. Next. So just for reference, we've included an example of a competency test whereby for the early initiation of breastfeeding, an assessor will wear a mama breast simulator, and the health center staff that's selected will end up having to instruct the assessor or the mother, role play with the mother on how to initiate breastfeeding or provide counseling on the importance of colostrum. Next slide. So knowing that this was a system implemented by the Quality Assurance Office, and there's not always necessarily interdepartmental coordination, we provided an incentive through the project for the QAO to make quarterly data available to the National Maternal and Child Health Center, as well as to the National Nutrition Program, following a suite of templates that were pre-identified. So there's already a handshake or an agreement to be able to produce this data for programmatic use. Next slide. So in summary, on a quarterly basis, the NNP and Maternal and Child Health Center will be able to have robust information on the quality of the health center facility, as well as knowledge and skills of the midwives and the nurses providing MIYCN counseling. Data will be collected through tablet-assisted entry and digital data centralized. It will be reviewed quarterly in collaboration between the national program and the Quality Assurance Office, and any implementation issues discussed. And then these results are used at the health center level in order to prepare quality improvement plans and to provide targeted coaching. And right now, the Maternal and Child Health Center and NNP are developing coaching guidelines to actually go and follow up on a random and a risk-based basis in order to support the health center staff in improving the counseling service delivery. So in summary, the maternal and child health and nutrition scorecard of the National Quality Enhancement Monitoring Program will be used to support the National Nutrition Program in generating this process data. It leverages an existing system rather than relying on programmatic supervision, which can be ad hoc and lack financing. And it provides incentives at multiple levels, at the provider and the central level, in order to institutionalize the system. It'll also be using a variety of other data sources to triangulate the outcomes and look at the overall theory of change for improved MIYCN behaviors. Thanks.
Thank you so much, Anne. And as you were talking on that, I just think it's so good for other countries. And what we love hearing is what different countries are doing. And I think what's key to me that I see happening is Cambodia is that they are leveraging for longevity. So I'm using two L's there because they're leveraging the existing system to really try and make sure that there's longevity in what they do. And that's to be commended. So thank you very much for sharing with us from Cambodia. Let's take a plane now over to the Philippines, because we're now going to have sharing from our colleagues in the Philippines. And you will see here that we are going to be looking at creating MIYCN-friendly health systems through the Asean nutrition surveillance system. And although our colleague Ellen is listed on the slide, it is a pleasure for us to welcome as our presenter, Jasmine Tandigan, who is the nutrition officer at the Nutrition Surveillance Division of the National Nutrition Council within the Department of Health of the Philippines. And Jasmine, it's lovely to have you with us, and the floor is now yours.
Thank you, Jane. Good day to everyone, and I would like to thank UNICEF, Alive and Thrive, and Irish Aid for this opportunity to be able to share the ASEAN experience in developing the ASEAN Nutrition Surveillance System. So, next please. So what are the goals of the ASEAN Nutrition Surveillance System? So it is actually envisioned to facilitate rapid reporting of key indicators on nutrition and its underlying determinants. The system is guided by the Global Nutrition Monitoring Framework, and it aims to use harmonized definition and globally recognized indicators to allow in-country and cross-country analysis of nutrition, as well as compare nutrition trends. Accurate and timely information that will be provided by the ASEAN Nutrition Surveillance System, or the ANSS, shall be useful to our policymakers in setting priorities, developing socially inclusive policies and programs, and evaluating interventions related to the elimination of all forms of malnutrition in the ASEAN. It shall also be useful to other national and local officials from both government and non-government organizations, the international community, researchers, the academe, and the community in general. Next. So what has been accomplished so far in the development of the ASEAN Nutrition Surveillance System? So it all started with a seminar workshop back in 2008, when the concept of establishing a regional nutrition surveillance system was put on the table. So the workshop was conducted with representatives from the ASEAN member states participating in. So the output of this workshop was actually to get them to commit or to give their support in the establishment of the regional nutrition surveillance system. So the results of the workshop went through the process of approval and endorsement of the different ASEAN bodies, which led to the integration of the establishment of the surveillance system in the ASEAN Socio-Cultural Community Blueprint of 2009. And it was approved as an activity officially of the ASEAN Health Cluster 1 Work Program 2015 to 2020. So after that, a series of multi-sectoral workshops were conducted to build the components of the system. The initial workshops were along the review of the nutrition surveillance initiatives of member states and sharing of good practices in nutrition surveillance. These workshops involved representatives from agriculture, education, health, and nutrition sectors. The ASEAN Declaration on Ending All Forms of Malnutrition, formulated in one of the workshops and eventually adopted by the ASEAN member states, established the ANSS, or the ASEAN Nutrition Surveillance System, as the monitoring platform of the operationalization of the declaration. So in 2018, the goals and objectives of the ANSS was updated in consideration of the 2018 Global Nutrition Monitoring Framework and the ASEAN Blueprint 2025 Monitoring Framework. The indicators were also reviewed, specifically the 3 sets of indicators: outcome indicators, intermediate outcome indicators, and process indicators. So a total of 100 indicators were identified. And then in 2019, an indicator prioritization survey among the ASEAN member states were also conducted to identify the minimum set of indicators that are available, sensitive enough to measure progress in achieving nutrition results. And the ASEAN member states, and if the ASEAN member state has the capacity to generate these indicators at the country level. So we came up with a total of 35 indicators, 12 outcome and 23 intermediate outcome indicators were prioritized based on the results of the survey. Parallel to the development of the ANSS is the development of the 2020 ASEAN Food and Nutrition Security Report, which gathered and verified data on the 35 indicators in the ANSS, as well as other health, nutrition, and related indicators. Next, please. So what were the challenges that the ASEAN has encountered while in this journey of developing the ANSS? So first, we actually just identified 2, but these are very huge challenges. So this would include that each country has their own system and timing of data collection, reporting, and dissemination. Then data disaggregation also differs by country. Thus, we identify the need to harmonize and standardize these indicators so that we can measure each other using the same parameters. The ASEAN member states also have different levels of capacity in countries in order to generate the data. Some countries would need support to strengthen or develop their capacities to regularly collect and report data of specific indicators. Another challenge would be the unavailability of indicators in some countries. Proxy indicators were suggested, but a review of these proxy indicators should be done to determine its compatibility for data analysis. So finally, next please. What are the key takeaways in this journey of the ASEAN in the development of the ANSS? So some of the key takeaways would be, number 1, and most importantly, is the importance of consensus and commitment of the ASEAN member states to move this activity forward. So one might also say that to achieve consensus, we must also arrive at a compromise. Next would be prioritization of indicators common across ASEAN member states, which facilitated identification of the 35 indicators. And number 3 would be building capacities on data generation, such that the members of the ASEAN will be able to better commit to providing data for the surveillance system. And of course, amidst all this, data quality is also of great importance. So in summary, next please. The ANSS will become a harmonized system where ASEAN member states can share data of key standard indicators on nutrition and its underlying determinants for in-country and cross-country analysis of nutrition trends to support priority setting, socially inclusive policies and programs development, monitoring, evaluation, ultimately for the elimination of all forms of malnutrition in the region. Thank you for your kind attention.
And thank you, Jasmine, for such an excellent presentation that's really showing the work that's been done. And I always think that when one hears about a journey, and that's what this really is that they often say the first step is the hardest. And that first step has been taken, and congratulations on that. And I do see that you said to us 4 C's. What's needed going forward is consensus, commitment, compromise, and capacity. And if those 4 C's are put in place, there's no doubt that you're going to have success. So thank you for sharing that with us.
Thank you.
Before we move to our next speaker, I do want to remind you, if you have any questions for any of our presenters, you are most welcome to write them up in the Q&A section that you will see at the bottom of your screen. So let's go from the Philippines to Indonesia. And as we go to Indonesia, it is our pleasure to invite colleagues from Reconstruct, which is the Research for Human Development, and it is part of the University of Jakarta. And as you will see, they are going to present to us on a COVID-19 related study that was done to assess food insecurity and undernutrition in poor urban areas within Jakarta. So our pleasure to welcome the Reconstruct team, and the presenter today is going to be Hafiza Jusril, known to many as Fiza. And so Fiza, the floor is yours.
Thank you, Jen. So good morning, good day, good afternoon, and good evening, everyone. On behalf of Reconstruct, allow me to extend a very warm welcome to you all. My name is Hafiza Jusril, and I'm here delighted to share about Reconstruct experience on conducting a remote survey in capital city of Indonesia, Jakarta. So this remote survey aims to capture the status and determinants of food insecurity and undernutrition in poor urban areas in Jakarta. And in this fairly short presentation, I'm trying my best to share our strategy on conducting the survey remotely, the response rate, as well as the challenges and the key lessons learned. Well, to begin with, one of the most important aspects on remote survey is contact listing. And here, because of the restriction due to COVID pandemic, we decided to make use of previous established connection. We are quite lucky because in 2019, we conducted a similar study. Its name Reach Every Children, that captured nutrition status of mother and child in urban slum. And at the time, we actually visited the mother and the child pair in 3 cities in Jakarta. So here on this study, we also decided to conduct a similar study in the same area. Next. So on the method, there are 3 components that we found quite unique especially on remote survey. First, on preparation, we learned that remote survey, especially on nutrition topics, it requires much more rigorous training. We train our enumerator for 2 weeks, combining online and offline method. While on the online, we involve daily piloting and feedbacks, while for offline, we focus on exploring the tricky question, especially on the food recall components. Then the second unique component is listing the contacts. So we contacted the cadres involved in our previous study, the Reach Every Children study, and asked them to provide contacts for our respondents. In Indonesia, cadres are the foremost guard of health services because they usually support the health community center. And for this reason, they are one of the best channels to get the most updated information on household, especially in the community, especially during the COVID situation as well. The third unique thing that we found as well on the method is about the quality assurance. So the challenge of this remote survey is the remote is not just between enumerator and respondents, but it also between us, the research team, and the enumerator. So during the data collection, we employ multiple measures to ensure the data quality. First, every enumerator was required to check the data before they uploaded the data. Second, the data manager will check the uploaded data and then contacted the enum for any outstanding issue. And enum was requested to resolve the issues within 24 hours. And lastly, we also check the 5% of recording for the quality. Next. So this is the flow of conducting a phone survey for each enumerator. We actually mainly follow the common procedure, especially on the consent. But the unique thing in this survey is we set an almost 24-hour hotline using WhatsApp group because Indonesia use WhatsApp group a lot. And this is for the means of troubleshooting. So because the phone survey is restricted by duration, and we also couldn't see the non-verbal cue from our respondents. So our enumerator is encouraged to take notes for any confusion. So they have to ask that to the WhatsApp group for troubleshooting. And we found there are a lot of questions about the food groups and food components. And every day during the data collection, the data and recording should be uploaded in daily basis. We set the deadline at 11 p.m. This to allow the flexibility on the interview schedules with the respondent. And by the next day, the enum would receive the list of outstanding issues that they need to resolve accordingly. Next. So this is the overall snapshot of samples and the response rate. So of 40 cadres that we contacted from the Reach Every Children study, 19 of them were responsive, and we were provided by over 2,000 contacts. We managed to call over 1,800 contacts and successfully collected 991 respondents. Next. The data collection was lasted for 32 days, and overall, in average, we received 32% response rate. And as you can see that the response rate is quite varied from day to day. At first, we set 2 successful respondents per day as a target, which means that enum has to call respondents as much as needed to achieve such target. But then later on, once we deemed that the enum could manage the speed, when we found that there was less error on the data, we set a higher daily target, so to 3, and then later to 4 respondents toward the end of data collection. We usually got a lower response rate when we start to call the new hamlets, but we also had a high response rate where the cadres on the hamlet were proactive on supporting the study. Next. So to quickly recap, what are the 5 key takeaways that we got from conducting this research? First, due to COVID pandemic and limitation to conduct face-to-face survey, we can't literally follow the common procedure and regular survey. But we try our best to monitor the data collection rigorously in daily basis. Second, while we are all aware that selected indicators were not phone interview friendly, for example, like anthrop or cost of diet, for those indicators that is important, we put multiple and layer of scheme to ensure the data collection quality. So we put that 24 hours WhatsApp group coordination. We also put multiple data check scheme. And the third, we use a Google Sheet to track data collection progress, but this monitoring really relies on a numerator compliance. While this facilitates timely monitoring, we think that it should be coupled with the WhatsApp group to ensure the data quality and information updates. And next, we found that the data is really highly dependent on software reliability. So we strongly suggest every researcher that intend to do the remote survey as well to choose a reliable CAPI software and be very familiar with it. And lastly, the data quality check could be done on a daily basis, but we learned that it consumes notable main days and that could be costly. So sometimes the remote survey is not as cheap as what people think. And I think that brings us to the end of presentation, Jane. So I'd like to thank you all for your time and attention today. I'd also like to mention that the Reconstruct team is here today, so please feel free to ask questions. Over to you, Jane.
Thank you so much, Faiza, for also a really excellent presentation and for choosing and taking the opportunity during this time of COVID to really see how a remote kind of studying and research can happen. And I'm sure that we will have some more conversation on it. So as we move to the next slide, please, I will also ask all our presenters that are with us to please join us, as well as I'm going to ask our colleague Prosper Dukura, who's from the UNICEF Lao PDR office, to also join us. So if I can, we can take the slide off and get all the speakers that are here on the screen. So thank you. Lovely to see you, Jess and Jen. Faiza, if you want to put your camera on. Jasmine, if you want to put yours on. That's great. Prosper, we hope we're going to see you as well. Thank you. So Prosper, I'm going to give you, as we start the panel, 2 minutes, because we would really love to hear from you about the work that is happening in Lao PDR in terms of work on a DHIS2. And I can see that you are traveling, so we really appreciate that you're with us. And let's hear from you for 2 minutes, hopefully, on what's happening in Laos PDR in terms of this DHIS2.
Thank you very much, Jane, and I hope you can hear me loud and clear. Good afternoon to you all from Vientiane. So first of all, I'd like to say thanks to UNICEF and Alive and Thrive for giving us the space to share our experience on the use of DHIS2 in Lao PDR. So very briefly, the system was developed and deployed in the country in 2016 with the support of key development partners such as WHO, UNICEF, World Bank, and LAX Development, with the support of Oslo University. The system is currently managed by the Ministry of Health, specifically the Department of Planning and Cooperation. The system currently collects routine data on maternal and child health, vaccination, health infrastructure, and hospital patient flows. Last year, with the support of the National Information Platforms on Nutrition, NIPN, we did a data mapping exercise. And what came out very clearly was that there are a number of indicators currently collected, over 700 indicators. But unfortunately, there were a lot of issues that we came across. For example, some of these indicators lack the indicator attributes, such as the definitions, the frequency of data collection, the level of data collection, etc. We also realized that key data or indicators on maternal, infant, and young child feeding indicators were missing from the system, and also those that relates to social behavioral change communication and management of critical interventions such as management of acute malnutrition. And some of the indicators were not also aligned with international definitions. So these were presented to stakeholders in the country, and the decision point was that we needed to revise and make sure that the indicators that are collected on the routine information system are fit for purpose. So currently, we are doing the revision of the MAE framework of the reproductive maternal nutrition, child health, and adolescent strategy. So stakeholders are rallying together to revise the indicators to ensure that they are fit for purpose. We are also working at revising the primary data collection tools, the registers, the forms that are used for this data collection. And also, Laos is the beneficiary of a global initiative by WHO and UNICEF, known as the Strengthening Nutrition Information Management System. So we are using that as an entry point to ensure that these indicators are revised and we ensure that at least they are fit for purpose to enable us to monitor routinely some of the things that we ought to be monitoring in the country. Thank you very much.
Prosper, thank you so much for sharing that. I'm going to ask you before I hope you'll stay with us, but if you do have to go, I want to ask you, Prosper, from the experience to date, what has been the biggest lesson learned that you can share with our other colleagues in the region through this experience? If you could say one lesson that you think is the most important that has been learned.
Yes, so one lesson I could talk about is that when you have engagement with the partners, government, for them to understand why they needed to collect certain data, then it creates room for ownership. They take the initiative, they have the drive, and they take the lead in doing this. So working with our government partners is very, very key on this journey of ensuring that we collect data for monitoring purposes.
So I took away from that what you've said is critical are two things, is understanding and ownership. And
Exactly.
if you have understanding and ownership, then that's likely to really lead to success when it comes to these data issues. So thank you, Prosper, and stay with us if you can, but we understand if you can't as well.
Sure.
And you will see on the screen a few more people as well. So I am just going to introduce that in addition to Pfizer, as she said, we also have some other members of the team that did the work together. And so it's a real pleasure to also welcome Ibu Lindawati Wiboa, as well as Pak Iwan Ariwan and Ibu Chow Novyati Rachmi. I know I'm not doing well in my pronunciations, but you will please forgive me and know that you are all really welcome nonetheless. As we go to the questions, Jess, the first question that's come in is posed to you, and it says that it was noted that it often takes at least 6 months to complete an MIYCF survey nationally. And cost is another reason why countries often don't conduct these surveys frequently, although they all agree that it is important to have timely data, especially in the COVID-19. So the question to you is, do you have any experience on how a country can mainstream MIYCF indicators, especially the new ones, into the national surveillance system in a cost-effective way while providing timely information to inform policies and interventions? So Jess, we want the magic bullet from you. Jess, you will need to unmute.
There you go. We have a 2-mute system. I think it's a really exciting question, and this is one of those things where I think that COVID-19 and the restrictions placed on us by COVID-19 have really pushed us to think of more innovative ways of doing data collection and to think outside of our comfort area, that we usually do large-scale national surveys, and then we have HMIS or our routine data information systems. When we think about how can we routinely collect data, there are some really interesting things ongoing, and the data administrative systems and the health system is a great place to start. But I think we also need to be aware, and my colleagues in government online here and the presenters, please feel free to weigh in as well. But we also don't want to overload the health system. There's a capacity limit to how many indicators a health worker can be collecting, and the capacity of that system to be collecting these indicators. Do we want to take a health worker's time to start asking a long series of questions on dietary practices? So I think we need to think a little bit differently, be innovative, think about how else can we collect this data. The use of phone-based surveys in the example of Reconstruct in Indonesia is really interesting. It's not easy. There's a learning curve there as well, but Reconstruct did it. The Gallup poll that I mentioned with the collection of dietary quality questionnaire is another great example. This is national data collection being done annually in almost 140 countries globally, and they're going to be collecting their dietary quality data. If your country is not currently part of the planned 90 countries to collect the diet quality questionnaire, your country can be added for a total of $25,000 at the national level. So there are other opportunities that we have for data collection, and I think we need to be flexible, innovative, and learn as we go. So modify, so we can do phone-based surveys, we can look at online applications, and we also need to determine what do we need at the national level. If we're collecting indicators for reporting, if we want minimum dietary diversity at the national level, we're going to have to do a larger scale survey. But maybe we need more timely data, smaller scale data at a subnational level that we can use to inform programmatic strategy. So I think thinking outside of our comfort area a little bit, how can we be more innovative? How can we look at phone-based surveys, online different methodologies, and different modalities of data collection to get the information that we need and to use that to inform? Thank you.
I'm going to, before I ask others to come in, because maybe Jen also has some ideas, but I'm first going to go to Pfizer, because I think that really is a good link in to a question for you that I was thinking of, is because, as Jess said, we're going to think out the box. Phone surveys might become more important. What type of indicators did you find are the most easy to measure through a phone-based survey, and which ones did you find were really not that reliable? And of course, if anyone else from your team, you'll tell me if anyone else from the team wants to add in.
So let me try to go first, and I hope Bajut, Bu Linda, and Pa Iwan can add me later on. So the easiest one is those that require straightforward question and answer, and it doesn't require another validation. For example, do we have to see something, for example, like socioeconomic? Sometimes we have to actually observe whether that question, the answer is correct or not. But during the last, this COVID survey, one we found very challenging is the one require food recall. I think Bu Linda and Mbak Jude could add more on that from our nutrition perspective, Bu.
Yeah, sure. Yeah. So again, I mean, the challenge in this COVID pandemic, because we could not do this face-to-face interview, but I mean, because you know, interview is an art actually. It's not just asking questions and then expecting our respondent giving us the answer just, you know, objectively, but you know, there are many things that we have to consider during the interview, reading the mimics and everything, whether the answer is actually right or wrong, or whether the answer is actually biased or not. But of course, with the phone interview, we cannot do it. So we have to really carefully select what kind of questions that we could deliver. Like with the dietary diversity questions, it is really a huge challenge, because even with face-to-face interview, I mean, it takes time for us to classify as fast as we can, you know, once they answer. Let's say in Indonesia, I think it's in most of the Asian country, our diet is really, it's terribly mixed. You know, when we say gado-gado is Indonesian salad, you know, everything could be in one plate. You know, sometimes it's 1 spoon, 2 spoon, 3 spoon, and then the respondent cannot actually, you know, tell us, you know, how many spoon of carrot, how many spoon of
so Linda, because we need to
cabbage.
move on, what one, I'm going to ask you to tell us which one did you find was the most successful? What would you say? Let's maybe share 1 or 2 that were successful, that really you found you got good answers with good quality data collection.
Okay, for example, okay, let me back again to the dietary diversity. We cannot expect much on looking at the quantitative part, but at least we could still see on the qualitative part, whether they consume it or not, whether it is still in the diet or not. Yes, it is overestimate, but if we insist the respondents to tell us on the quantity side, it is biased anyway, you know. But we could actually, you know, try to compensate this with a larger sample size, you know, so it's sort of like balanced out, you know, those kind of things. So there's here and there, you know, one is weakness, but then we try to find a way to dissolve the bias.
Jen, I'm going to ask you, because when we look at formative research, it's usually considered really expensive, and it really requires intensive kind of interaction, and possibly in the past we've always said face-to-face. But I was wondering if you've got any thoughts, or are there any low-cost alternatives for collecting high-quality data on nutrition behaviors, especially in these kind of times? I want another magic bullet from you, please.
Well, I have no magic bullet, unfortunately. And I was about, before Faiza's presentation, I would have told you phone surveys, but now I've learned that those are a lot more challenging to do, especially for formative research, right? Where you're trying to dig at why people do what they do. So I think that the first thing I would say is use what data you already have. I mean, oftentimes there is a lot of good data at the country or the subnational level, and we can reanalyze it, we can cut it, slice it in a different way, and get a lot out of it. So especially during the COVID era, I would say that's the first choice. Then there's a lot of you know, exciting methodologies out there. One that I'm really interested in is content analysis on social media. Although it won't work for everything, people are online all the time and reacting and responding and putting their thoughts and feelings out there. So there are methods out there for using content analysis on social media. And then I would just suggest like looking at the research and the peer-reviewed literature that's out there. Oftentimes we try to reinvent the wheel with formative research, and sometimes there are some great protocols that have been published. Alive and Thrive just published one on the effectiveness of breastfeeding policies. So look for those protocols, the data tools that are already out there, and try to translate them to different technologies, I think. No magic bullet here, Jane.
No, but Jen, I think those are all, it's what Jess started off by saying, is we need to think out of the box. We need to, and I like your idea of also making use of data that is existing there that we haven't yet really harvested enough, benefited from enough that we can. So I think there's some great ideas there. I also see a question here that's asking, are there any resources that offer virtual training on how to administer questionnaires that collect data for MIYCN indicators? So do we have any virtual training courses, and perhaps both Alive and Thrive and UNICEF? Should I start with you, Jess, if you've got anything about the virtual training on how to administer questionnaires?
We do not. So I'm really interested to see if we have anything at the country level. I think one of the problems of developing a global or regional resource for training is that the IYCF is very much dependent on the language of specificity. So it's difficult to create a training in English and then having to be translated at the country level. So I think at the country level, this would be really interesting to see how you can build capacity. But I take what Linda was saying as well, and that the measurement of dietary consumption in some ways can also be a bit of an art. And so how do we translate that magic into ensuring consistency across enumerators as well? I come back to I mentioned it multiple times now, but the diet quality questionnaire, which is going to be collected, is a close-ended question. So it's not an open recall, and it's not looking at a 24-hour dietary open recall. It's close-ended questions, 29 questions. And what they're finding is that 29 sentinel foods are able to better measure dietary quality. So there is opportunity to also modify how we're collecting diet quality indicators and looking at this application to children as well, because a close-ended question is a lot easier to administer compared to a 24-hour dietary recall and open-ended questions where you need to probe. So there's no probing involved. Thanks.
I'm going to come to ask a question to Jasmine, and then I am going to I'll look back on the questions that are also now coming in. Jasmine, I want to ask you is, could you share with us how ASEAN is going to report on the Asian nutrition surveillance system? And how's it going to be shared globally and within the ASEAN community?
Yes, thank you, Jane. For the ASEAN nutrition surveillance system, its intention is to be web-based. So at certain periods or at certain intervals, the ASEAN member states would have to upload their data that they gathered from their respective countries. So now we are just focusing first on the 35 core indicators just to make sure that to get the system up and running. But for now, it's still under, the system is yet to be developed. We are still finalizing the indicators for now.
As we said, it's a journey and you've taken the first step, but it's really useful to know. We're coming close to the end of our question and answer time. So I also just want to ask each one of you, and I'm going to give you a minute to think, not even a minute, 30 seconds to think about it. If from everything you have heard on this webinar, there was one message that you felt was really critical for leaving with our country colleagues as they journey on this optimizing MIYCN policies and programs through strengthening data and information systems. If there's one thing that you think, if I had to leave with one message from your experience and your knowledge, absolutely from your experience and your knowledge, what would it be? So I'm going to go with the order that people are appearing on my screen to be totally fair. So I'm afraid, Jen, you're the first one. What would be your one message?
I think it would be to leverage existing national monitoring systems and try your best to integrate indicators for nutrition into those systems rather than reinventing new ones, and look beyond HMIS because that's a tricky one. There are often other monitoring systems out there. Over.
Wonderful message. Faiza, you're next. What would you leave your message to our country colleagues?
That would be, during the COVID pandemic, there are a lot of restrictions. So we have to keep trying and finding innovative way to outsmart the restriction to find the best solution for any issues, especially on research.
Wonderful message, really, thank you. And next is you, Jessica.
Well, those two are really good, and I agree with both of those. So I'll just be a bit simple and just say, you know, the title of the presentation, what's measured matters. So it's that we have to make sure that we are measuring our indicators and that we're focusing on these process indicators. We have to know what is our current status of implementation to make that modification. And just to add to both Jen and Faiza, I completely agree, but let's be innovative. Let's not reinvent the wheel at the same time. And rather than try to force indicators into existing systems where it might be very difficult, there might be really, you know, tangible ways of collecting data that we're not fully utilizing. That's hopefully a little bit easier than the experience of Indonesia with phone-based surveys. So let's be flexible and modify.
Jasmine, what about you?
Yes, I would like to take off from Jane's synthesis of my presentation where she identified the 4 C's. So it's important that we gain consensus, commitment, compromise, and capacities so that we get things up and running. So for the ASEAN surveillance system, it's been a very, very long journey and still ongoing. But what we realize, it's really the commitment of the ASEAN member states and our partners in helping us pursue this endeavor. Thank you.
Wonderful, Jasmine. So what I've written down as you spoke is I've just got some words here. Going forward, we need to innovate, we need to leverage, we need to outsmart. We need to make sure we're doing it. We need to have a level of flexibility, and then we must always look for consensus, commitment, compromise, and capacity. But above all, we have to do it because what measures matters. And so with that, I want to give a great thanks to all our wonderful presenters and panelists. And thank you all for having given up the time, and Prosper for also joining us. Because I don't think I gave you one word, Prosper. I saw you right at the bottom of my screen. So Prosper, before I hand to Roger, you get the last word. What would you say is the lesson learned?
So we need to work very closely with our government partners. Once they take the lead, success is assured.
Super. Partnerships, I'll add to my list there. Thank you, Prosper. So it's now back to our closing of this session. And so it's my pleasure to hand over to Roger, who definitely needs no introduction as the Regional Director of Alive and Thrive. So Roger, your closing remarks and some exciting news about an upcoming workshop.
Yes, thank you, Jane. So this webinar reminded us that what's measured matters to optimize policies and programs for maternal and child nutrition. The new guidance and indicators, they have not been really disseminated widely before now. So it is a clear action for us to make sure they will be used in our surveys, in the surveillance and other assessments. We were also reminded that we need to use data strategically throughout the program cycle and to complement both quantitative and qualitative data to better understand the situation and design for policy and behavior change. The importance of process indicators were also highlighted. So also a question for Jess is like, where can we get access to those new global indicators? They seem to not have been widely disseminated yet. And I think it would be useful for the countries to get hold of that report that you showed on the screen. We also got reminded to look at available data again, especially during the challenges with collecting data during COVID-19. Harvest more from what's been already collected. I really like that idea. So we should not forget about doing the desk reviews and make sure we put our data in the public domain. It can be hard sometimes to get hold of all the gray literature if we don't focus also on data dissemination. I want to follow up on what's measured matters. And at the 2016 and 2018 workshops, we also had SDG reporting on the agenda. And the recommended breastfeeding and infant and young child feeding indicators, or complementary feeding indicators, they are optional indicators in the global framework, reporting framework for SDGs. But they are highly recommended and encouraged to be reported on at the country level. So I think it's an action point for all of us to kind of link up with the focal point for SDG reporting in the countries. Is usually a multi-sectoral reporting, and also to assess the reports that has been produced so far to make sure that breastfeeding and complementary feeding and other of those recommended indicators have been included, because what's measured matters. We also listened to some excellent presentations showcasing how Asean and the countries use data to inform policy and programs. So it's lovely to see that everyone doesn't need to work from home with Prosper joining us from the car and while he was traveling. I want to thank all the presenters for these great presentations. The participants, I want to thank Jessica, Roland, Ling, and also Alison joining us from Seattle at this hour from the organizing committee. And to you, Jane, for always doing very impressive facilitation of these workshops and webinars. I think we should also make sure we turn the camera on for Belle, either at this webinar or at least for the next workshop. because we wouldn't have managed to do this so smoothly without her high-tech support behind the scene or behind the screen. So thank you, Belle, for that. So this is the third and the last webinar before the next biennial workshop. And we do recognize that the coming weeks and months, they are quite busy for everyone. It's also a lot of public holidays coming up in our region. So we have therefore scheduled the workshop in March. It will take place the 9th to 11th of March at 2 p.m. Bangkok time. So that's Tuesday, Wednesday, and Thursday. It's easy to remember, it's the same week as the International Women's Day. And we hope that these days work for all of you and that you can save the dates in your calendars. And I just want to say a few words about these workshops. These 3.5 days in March will be filled with a combination of online and offline face-to-face engagement, depending on the COVID situation in your country. So we hope that some of the country teams can do like you did today, that you actually gather in a conference room. So the difference will be at the workshop that you will be a bit offline and online and offline. So you will kind of disconnect to do some group work and then connect again to report back to the broader group. And the organizers will reach out to you the coming weeks and months as we finalize the program and to ensure we come all very prepared to the workshop. And the workshop will include presentations to highlight both global and country best practices, panel discussions, and the already mentioned breakout sessions. We also plan to do a recap from the 3 webinars. And what's even more exciting is that we will celebrate your progress for the targets you set for breastfeeding at the 2018 workshop in Da Nang, and also the complementary feeding targets that you set in the 2019 workshop in Bangkok. So I think it will be useful if we circulate the previous workshop reports with you again, and also the country-specific targets. Some of you are new to this group, and others might want to have a reminder. You will also have the opportunity to set new targets and refine strategies and roadmaps based on the strengths within your country team. And you can also propose areas for technical support by UNICEF regional office or Alive and Thrive regional office or our network of partners. So I would also like to thank Irish Aid and the Bill and Melinda Gates Foundation. They have been supporting these biennial workshops since 2013, and also the strategic activities in between. So we are grateful for your support and for enabling us to work together for greater social impact for families and children in Southeast Asia. I would like to end by wishing you all the best as you wrap up activities this rather challenging year. And on behalf of the organizers from UNICEF, Irish Aid and Alive and Thrive, I'm wishing you a safe and happy holiday season. Thank you.
So thank you, everybody, and goodbye.